Hello and welcome, everyone. I am Rachel, Community Manager here at Alloy Women's Health. We are a telehealth platform bringing science-backed, evidence-based menopause hormonal solutions direct to your door. I want to quickly let you know today's code is GWT, as in Grown Woman Talk 20. That's GWT 20. You may enjoy $20 off purchase today on myalloy.com using that code. Listen, we are most fortunate to have time today with Alloy's Chief Medical Advisor and now author, Dr. Sharon Malone, for a conversation. She's about to set out. She's already begun her book tour. So we're especially grateful for her time today. Listen, I just want to say quickly on the aside, if you have not already ordered Dr. Malone's book, you may pre-order it now. Please do so. She didn't ask me to say that. No one at Alloy asked me to say that. It is coming from me. I read the book. It is in all ways everything that she is. It is kind and funny and smart and thoughtful and helpful in ways that you'd want your best girlfriend, your sister, your mom, your aunt to be, in that she takes you through essentially your reproductive years to the end of your years, focusing on health, your best health today, shoring up your health for the future. It also importantly amplifies the experience of Black women in particular, while helping all women navigate and chart out a path to improved health over the course of a lifetime. It is the resource, I'll just say this finally, that I felt deeply when I read it. It made me tear up, quite honestly, at the end, because all I thought was of the mothers, the grandmothers, the generations of women before us who would have benefited from Dr. Malone's book. Welcome, Dr. Malone. Thank you for being here with us. My first question to you is, why this book and why now?
Thank you, Rachel, for being so kind and talking about my little book. I wrote this book for a couple of reasons. One, I realized that there's not really much out there that is a resource that addresses the whole of a grown woman's experience. And, and we spend a lot of time talking about perimenopause and menopause, as well we should, because these are really under-discussed issues. But I wanted you to have the totality of it, and to start from simple things like how to pick a doctor to how to write your will. I think that there are not enough conversations about women's health in general. And I think that we spend too much time, perhaps an inordinate amount of time, in our reproductive years. But what about everything else? What about after 40? And this book really came from a lot of the conversations I've had with my friends and my family members, about very basic things that I realized that they didn't understand about this changing medical environment that we find ourselves in.
Great. Thank you so much. I wanted to sort of ground us in just a few questions that come up a lot around perimenopause and menopause. And then we're going to get right to questions that came directly to me, and then open it up to everyone joining us here today. First of all, the various forms of estrogen, if you would lay that out for us, and knowing importantly which one is for you, which one may not be for you.
Right. Well, let me say, estrogen in its various forms. You can take it as a pill, you can take it as a patch, a spray, a vaginal cream. And which one of these, but in the broad categories, is either oral or transdermals. And transdermals just means that it either goes directly into your bloodstream from the skin, or sometimes in the vagina, if you're just using that type of estrogen. Which one to take is really not that important, to be quite honest with you. There may be certain special circumstances where a transdermal would be preferable, but I think that the overarching sentiment is this: estrogen is estrogen, however you take it, it works. And whether or not you use a pill or a patch, it matters for convenience. which one are you most likely to be compliant with, a daily pill, a
Mm,
twice-a-week patch, or a daily spray? These are important things because it doesn't matter, which one, there's no perfect answer. It's the one that works for you. And
mm.
I think for another thing to really consider is cost,
Yeah.
and a lot of the prescription medications, depending upon which one you choose, there's a price point variation. The least expensive option is usually the pill, the
Mm,
estradiol pill. But again, which one to choose means, sort of what you better than anyone else. What are you most likely to remember to do? Because consistency is really important. And again, aside from certain special circumstances where a transdermal would be preferable, and those might be if you've had a history of a blood clot, if you smoke, and that's
mm.
something I think that women don't really understand, that smoking in and of itself is not a contraindication to taking estrogen after menopause. As a matter of fact, it puts you in a higher risk category. So achieving some of the benefits of using estradiol would be better. But again, in that circumstance, a transdermal or one that goes directly into the bloodstream would be preferable. But for the 95% of women who are making this decision about whether to use hormones or not, it's a matter of cost and convenience.
Terrific. Thank you so much. As the conversation around menopause has just gotten brighter and louder over the last few years, um, I'm noticing now with women over 60 their um, questioning their if it's safe, if it's effective to take MHT, and I wonder if you can speak to that a little, and answer to those women.
Sure. The one thing that I want everyone to understand is the overwhelming, I would say, the preponderance of the information that we have about hormone therapy still comes from the same study that on the other hand, we're
Yes.
like, that study was terrible, the Women's Health Initiative. However, we did learn there were some positive things that came from the Women's Health Initiative, and I don't think that we can lose sight of that. The majority of the women who were in that study were over 60. The average
Right.
age 63, and you could be in that study anywhere from 50 to age 79. Now, that being said, what we learned from the Women's Health Initiative is that if you are going to achieve whereas the benefit risk ratio most favorable, it is most favorable in women if you started at the time of natural menopause, whenever that is, or if you've had a hysterectomy or a chemo or whatever reason why you're menopausal. It's best if you take it before age 60 or within 10 years of whenever you've had your last period. But remember what I
Okay.
told you, the average age of women in that study was 63, and there
Right.
were who were starting hormones at 75. Now, again, that risk-benefit ratio changes as you get older. There's a little bit more risk, perhaps, for a little bit less benefit. Like you won't get all of the cardiovascular benefit. You won't get all of the osteoporosis prevention benefit the later you started. But again, I don't want to say that it's good at 60 and it's terrible at 62. It is not.
Sure.
We
Okay.
have a lot of evidence of women who have taken hormones and the oral estrogen too, not even the transdermal, over the age of 60. So I say that to say there's no hard and fast parameter. We don't draw a line in the sand because, again, some women will have had their last period at 55. So
Yeah.
if you're 62 and 63, you don't forget, you're still within that 10-year window. So over age 60 or more than 10 years really, just requires a little bit more conversation about your treatment goals, your particular risk factors, and what benefit that you are expected to achieve from that treatment. So not a hard and fast rule, but just know that it requires a little bit more conversation. And that's just for the systemic estrogen, either oral or transdermal. Everybody, regardless of age, can use the topical or vaginal estrogen and probably should. So that
Right.
only applies, this conversation is only when we're talking about systemic estrogen.
Terrific. Thank you so much. To piggyback off of that question a little bit, I'm hearing this a lot as well. I'm sure you have throughout your career. Should I stop taking hormones and when?
See, I hate that word should. What should I do?
I know, I know,
You
I
should
know.
do whatever it is you want to do. How about
Yes,
that?
yes.
And I think that there is no absolute time at which a woman should stop taking hormones. And I'll be perfectly honest, I've been on hormone therapy since I was menopausal. I've been on for 15 years now. I have no plans to stop. So unless you have a contraindication or a reason why you just want to, and that could be personal preference for whatever reason, you can stop. But if you're going to stop, see how you feel once you're off your hormones.
Sure.
But there's
Yeah.
no should in this. It is a matter, if you are still having symptoms once you come off your hormones. I mean, I don't want to give the impression that there's some benefit to stopping. It is not.
Right.
You
Right.
can take
Right.
hormones for as long as you want to take hormones, and as long as you have no other contraindications, and particularly for women who are at risk for osteoporosis, the reason for continuing is because once you stop your hormones, all that bone density that you've preserved, you'll start to lose it again in the 5 or
Yeah.
6 years after you stop your hormones. So again, no should. Again, personal preference. And that's really what the message that we're trying to get to women at Alloy is that this is about agency. It is about
Yes.
information. And don't let somebody tell you that, that what you should or must or can't have. The more information that you have, the better decisions you can make about whether or not this is right for you.
Dr. Malone, as you're speaking, I'm reminded of the several times I've heard you mention the release of the WHI study and sort of the backlash you experience, not backlash, but the wave that you experience in your practice, in your office, in conversations with patients. And then those women who said, well, I'm just gonna keep going, and I would love one day to hear from some of those women who, your patients or otherwise, but who said, I'm just going to keep going. Can we just keep at this? Because I feel good. Or I stopped taking them because of fear of this study, but actually, can I get that script back because I'm not feeling so well. Right. And it's sort of like agency in the shadows. But the truth is, there are those who just kept going because it was doing right by them.
Not only did I keep going, I think I started hormone therapy clearly after the Women's Health Initiative came out. So I was aware of what the implications were before and how we discussed hormones during that terrible and tumultuous time when we were trying to backtrack and explain ourselves. But the reality is that I read the study. I read the study in real time. So even 21 years ago, when there was rampant fear mongering going on, I read it and I was like, that wasn't that bad.
Right.
I don't know why people didn't actually read it. And the farther you get out in those concentric rings of doctors, you would expect the people who would know the most would be OBGYNs, right?
Right.
Probably only about half of them actually read it. Then you get beyond, then you get to primary care doctors, and then it's less cardiologists, endocrinologists. Those circles of lack of knowledge just kept getting bigger and bigger in real time, and it's only multiplied over generations. And so now there's a whole generation of OBGYNs who've never really read the study. They've just been taught and the same things and the same fears that women have had and sort of steered away from it. So yes, there have always been women who've continued because they tried to come off their hormones and they said, I'm miserable. A lot of their symptoms came back, and I didn't have a compelling reason to tell a healthy woman who was doing well on her hormones that she needed to stop. And that's been my practice even from 21 years ago this happened.
Excellent. Thank you so much. I also hear from women who've suffered with fibroids, endometriosis, female troubles, as you share in your book, and have a fair amount of anxiety about stepping through perimenopause and into menopause. Anything that you might offer to those women, that large swath of women, as they navigate perimenopause and menopause and are interested in hormones?
Yes. Now, here's if there's any good news about fibroids and endometriosis, is that these conditions tend, even though they are dependent upon estrogen for the maintenance of their fibroids and endometriosis, after menopause, they do get better. So at the very least, when you get to menopausal age, your fibroids, no matter what trouble they've been causing you with heavy bleeding or even just the bulkiness of the fibroids themselves,
Right.
Once the estrogen sort of goes away or really goes down, that gets better. The same is true for endometriosis, because if you think about it, for women with endometriosis, one of the treatments that we have for women with endometriosis, you know what we do? We put them in temporary menopause, and often in anticipation of surgery, but you take away the estrogen and just sort of shut everything down and the symptoms will regress. The problem is if you let a woman have her cycles back naturally, the endometriosis will tend to come back.
Okay.
However, and here's a big however, you say, well, it's the estrogen. You know what the other treatment is for women with endometriosis? Birth control pills. We use birth control pills all
the time.
All the time for suppressing endometriosis. So it's not the estrogen itself that's the problem. It's the cyclical nature. When the estrogen goes up in a normal cycle and it goes down when you have when you get your period. But once you're on birth control pills, you're on the same every day. So that actually suppresses endometriosis. So what does that mean about menopause? That means that if you have either of these conditions, they're likely to get better and regress during menopause. What does adding hormone therapy back after you're like, oh, great, now I don't have to worry about my endometriosis. Am I going to make it come back with hormone therapy? Answer that question. Typically not, because the amount of estrogen that you take every day is much smaller than what you would make in a normal cycle. That's one. It's only about a quarter to a half the dose of even what the lowest dose birth control pill is. And remember, it's not just the estrogen, it's the cyclicity of it that causes the problems. And when you're on birth control pills, you stay level. When you're on menopausal hormone therapy, you stay level. So I have not had anyone ever personally from my 30 years of experience who has gotten to menopause and then their symptoms are better, and I put them on a low dose menopausal hormone therapy to treat their symptoms, and have their either of those conditions get worse or come back.
Terrific. Thank you so much. Okay, we're going to start with questions that came to me for you, and then everyone who has already put their questions in the Q&A, I will hit those right afterwards. This is actually a perfect segue to what you were just saying. Here's the first question. Why are oral birth control pills still the go-to for symptomatic peri women when the hormones are synthetic and way higher dose, and the side effects are lower testosterone and low libido?
All right, I'm gonna take a little point of privilege here to say this.
Please.
I don't know what's going on, but there's a lot of birth control pill bashing going on out there in cyberspace. And
interesting.
And I'm going to say this, that for womankind, there has probably not been a medication that has been as important in terms of changing the course of our lives, giving women reliable birth control and giving them control of their own fertility has been seismic. So I can only countenance a little bit of, like people who are bashing birth control pills. They're great for most women. If you don't tolerate it for whatever reason, we have alternatives. But remember, we're going to stick with the things that are applicable to most women, not for a specific woman. And let's be clear about that.
Sure.
The reason why we use birth control pills in perimenopause is that by definition, in perimenopause, you're still getting your period. And for a lot of women, it's the periods and the bleeding that becomes a problem. So your periods are too long, they're too often, they're too heavy. And if that is the case, if you have bleeding problems during the menopausal transition, then the thing that works best for them is a low-dose birth control pills, because it gives you cycle control, not just control of your menopausal symptoms, because you don't need as much estrogen as in a birth control pill to control your symptoms. but you do need it if you've got cycle control issues. And menopausal hormone therapy, even though it can be quite appropriate to use in perimenopausal women, just understand you're not going to get the cycle control that you want. And the second reason why we use it in perimenopausal women, even though we talk about, in the perimenopausal phase, you're on your way to the end of your fertility, it's not gone. So if you have a sexually active woman who's sexually active with a male partner and she does not have another means of birth control, then you not only get relief of your menopausal symptoms, but you get reliable birth control. And for those of you who think that you can't get pregnant during perimenopause, yours truly here, my mother, I'm sure, was hoping for menopause, and she got you truly instead when she was almost 45 years old. So it happens. So those would be the reasons why, in all honesty, a birth control pill would be preferable. You need cycle control, you need birth control. And it's not forever. You're going to only be on a low dose birth control for those reasons until you get to menopause. And then once you get to menopause, then you can sort of seamlessly transition from birth control pills to menopausal hormone therapy.
Which you also did. You shared that story as well. Yeah. And it was sort of a seamless transition for you. And interestingly, you've also shared, just the science of it, you just did, that the estrogen in birth control pills is higher than it is in menopausal hormonal treatment, and therefore sort of speaks again to this weird argument that people are having about the if it's okay for you, if it's healthy for us, if it's going to hurt us as we age, when we need just different kinds of protective measures, if you will.
And and here's another misconception I want to clear up, is that we get into this, it's synthetic versus it's first.
Right. Okay.
Let me say this.
Speak to that. Yeah.
Other than Premarin, all estrogen products, be they birth control pills, be they menopausal hormone therapy, are synthetic. Synthetic is not a medical term. It just means that it's made in a laboratory. Natural means it's naturally occurring. The only naturally occurring estrogens that we use are currently is Premarin. And why is that naturally occurring? Because it comes from pregnant mare's urine. Now, PETA exceptions, taken here. Just my personal preference here, getting something from a pregnant mare's urine is not preferable to something that's made in a lab.
Right. Got it.
And physiologically, it does not make any difference. So don't get caught up in the language of synthetic and what's natural. Bioidentical does not mean natural. Those are not synonymous. Bioidentical just simply means that when this company makes this medication, estradiol, in the lab, which makes it synthetic, it is bioidentical. If you drew it on a chalkboard, it's the same chemical molecule as the one your bodies make. So again, don't confuse those two.
Terrific. Thank you. What is the best way? I love this question. What is the best way to handle a PCP appointment to be sure that you are receiving informed choice around MHT, not being given bad data based on old bad news, and not having symptoms discussed? This is another great reason to get your book home in on what to do, how to walk into that office.
Right. I think it matters sort of how you plan for that discussion, because I think it helps on the front end to even ask your PCP or the person, do you treat menopause? A lot of them don't. Because again, as I told you, when you make those concentric circles, your OBGYN, that's your best bet at finding someone who knows what they're doing. And then as you start expanding that circles, the knowledge gets less and less. So that's a first place to start. And if they tell you straight away, no, I don't treat, or we don't typically prescribe that, then you don't even need to waste your time, because you're going to spend more time trying to educate your doctor than you are going to get the care that you need. And that's really why Alloy exists, because we are here for those women who cannot and do not have access to informed physicians. Because I think that, the one thing I want women to understand is that menopause is something that works really well. It's not like we don't understand what it is or what starts or what works. The North American Menopause Society revised their guidelines in 2022, and everybody agrees the most effective treatment for the symptoms of menopause is menopausal hormone therapy. Now,
Right.
and that's just end of sentence.
Yeah.
And so finding someone who knows how to prescribe it is important, because if you have someone that doesn't know what they're doing, then yeah, you're going to waste your time on that visit, or you're going to waste your time trying to convince someone to give you something that you've already done your homework on. So again, a simple phone call. Hey, do you do this? Do you not do this? Going to menopause.org to see if there is a menopause trained practitioner in your area. Yes or no? Go to that person, but don't spend your time or spin your wheels on
Right.
talking to a doctor and trying to educate them about something, so
Yeah.
go where,
Thank
as we
you.
say, go where the money is, and that's
So
where it is. Where's the information, then that's where you should be.
good. Very good. How should we monitor our own HRT journey? For example, when should we try going off HRT? You spoke to that. Should we, and if so, when, get levels checked from time to time? I am working with a new fabulous doctor who is focused solely on menopause, but I also want to be informed. I'll be a year this May, I believe she meant to say a year without a period this May. And I noticed if I even go a day or so later switching my patch, if I think she meant to say if I miss a day or so switching my patch, I get a couple of hot flashes.
Yeah,
Mm.
because guess what?
Mhm.
Your estrogen went away, when your patch ran out. And,
Yeah.
and that's how quickly you will know whether the medication that you're on, the estrogen, is it the right dose? Is it not the right dose?
Mm.
On the right dose when your symptoms go away. That's why blood testing and levels of estrogen, of getting your estrogen levels checked is not important. I don't care what the number is. You start
Yeah.
a medication, you're on the right dose when your symptoms go away. And there are very, very few circumstances in which I would say, yeah, sometimes you do need to get hormone levels, and I will check them on, like the 5 or I'd say 2-3% of women who I have taken them up the ranks, and I've like increased, and they're still having problems
Mm.
and they're still symptomatic. Then it's helpful for me to get a hormone level, because I have to ask myself, are you absorbing it? Is
Right. Oh, okay.
there's some
Hmm.
other reason why, if I've got you on the highest dose that I feel comfortable giving you and you're still symptomatic, then we've got to sort out that problem. Well, why are you not? If it's an oral medication, maybe you switch to a transdermal or vice versa. That's helpful. But just for making treatment decisions on a person who's coming in who's symptomatic, do I need hormone levels before we start? No. Am I going to monitor your hormone levels after you're on it? No, because you're going to
Hmm.
tell me I'm good when you're good. And if you said,
Right.
sleeping through the night, my hot flashes are gone, then I'm like, we're good.
I just want to amplify for a moment what you illustrated. That's so important, I think, for all women to hear is that you believe what women are telling you. You believe what your patients are telling you. And I think it's so important that we, as lay people, as patients, maybe as doctors going through perimenopause and menopause, we're able to speak with practitioners who not only know the science, the nuances of it, but believe us when we say, I've got a host of things, but maybe not these that you recognize as being
Mhm,
symptomatic. I'm
mhm.
telling you, and anyway, I just want
Right,
to highlight that.
right. I mean, no one knows how you feel better than you do.
Right.
And that's one of the things about the doctor-patient interaction that's really got to change, and particularly, and
Mm,
when I say, the patriarchal nature, it's possible to have a patriarchal relationship with a woman as your provider. So
sure.
it's
Yes.
not a man-woman thing.
Yep.
It's the
Yep.
nature of the interaction that's
Yes.
patriarchal. So we're not
Yes.
men bashing here. It's
No,
how
no.
we were all trained. And so being able to listen and believe women when they say what they say, you can't say to someone, well, you can't be having that because
Right.
whatever the reasons are. If you said it, I believe it, and then we have to figure out a way to resolve why we are not getting the results that we want and figure that out.
Terrific. Thank you so much. Someone asked why in my post early menopausal years the hot flashing continues. I think probably it sounds like the remedy has just been spoken.
Right. And you think, and everybody's menopause and perimenopausal journey is a little different, but there are a lot of commonalities. So let's
Mm.
get that straight. Everybody is like, oh, we're all unique in everything that we do. But there are some things that are kind of, have, as we say, it's not the same, but it rhymes. And
Mm.
most women will have hot flashes starting in the perimenopause, and it will continue for a few months, years, even after you've had your last menstrual period. Eventually it stops. But to be quite honest with you, for some women, it's months. For some women,
Yeah.
it's years. For some women, it's a decade or more that they're still having hot flashes. So I would say to this, on the front end, you don't know whether you're going to be in the months category, the years category, or you're still having hot flashes when you're 75 years old. My advice to you, if you have them, you should treat them, because
Mm.
hot flashes are not benign. Let's say that, they're not funny. We make fun of them, in the, TV. Everyone's like, oh, here's a woman with a fan. But the reality is hot flashes have implications for cardiovascular disease. They increase your risk. They disrupt your sleep. And we know that women who have persistent hot flashes have more hypertension and are more likely to develop lesions in their brain, which are called these white matter lesions. And for those of you who want a detailed explanation, please read Dr. Lisa Mosconi's book, The Menopause Brain, where she explains where the estrogen and lack of estrogen really affects not only the metabolism of your brain, but the structure of your brain. So you've got hot flashes. Don't think that, the solution to that is I'm going to suffer through and wait until they go away. They will eventually, maybe not.
Maybe. And
Maybe.
perhaps a
Right.
lot of damage is done by then.
Right.
Okay, here's a question. What to do while on, and let me just say this also, you are not the physician of all the people
Right.
who are asking
Right.
questions. And so for those of us joining us today, if Dr. Malone will let us know if that's kind of derailing in any way. Okay. What to do while on a max dose of HRT, estradiol, via ring and oral progesterone. I'm still waking up at 3 a.m. almost every night. My mother had the same issue in perimenopause and beyond. I'm not stressing, no crazy thoughts. I don't need to go to the restroom. I'm at my wit's end since 3 years of this.
Right. And let me be clear about this. I would say for hormone therapy that what works with sleep the best, if you have to say what's the best thing that's going to happen, is that if hot flashes are waking you up at night, if you've got hot flashes and night sweats and I give you estrogen and I make those go away, then those are the people who are going to get the most success from just estrogen itself. But sleep is complex. You have to look at if you are taking estrogen and you are otherwise asymptomatic, you're not having any other of those menopausal symptoms, and sleep is your only problem, then sometimes it's a matter, that's when you need to go see a sleep specialist. Estrogen may or may not be the answer to everything. Maybe you have sleep apnea. Maybe there are some underlying behaviors of yours that are influencing your sleep. And that's not patient blaming. It's just saying, what is your sleep hygiene like? What are you doing? And let's be clear too, sleep disturbances or a change in the quality of sleep is something that happens with aging. It happens to men and women. As you age, your sleep is different. So I'd say, don't think that maxing out estrogen is going to solve every sleep problem that you have. Sometimes, just on the front end, what we do is we would use, it depends on what type of progestin you use, whether you use a natural progesterone or micronized, I say natural, I don't want to say that word, a bioidentical progesterone.
Okay.
because that tends to make you sleepy. So changing to that is a good, is a good first step.
Okay.
But the reality is that no, the answer isn't not keep escalating your estrogen dose. It's then that's a go get checked out what's wrong with your sleep issue.
Okay, terrific. Thank you. We're on the last one here that came to me directly. What options are left in perimenopause when night sweats and insomnia are not resolved? Oh, I'm sorry. I just read that, didn't I? Okay, that was it. That was it. Here we go. I apologize. Okay. So we are turning now to our questions of those who are on the call with us. Here we go. I started transdermal estrogen in 2019 at 51 after consultation with NAM's OBGYN for severe perimenopausal symptoms. No progesterone needed because no uterus. However, in July of 23, a mammogram showed increasing bilateral breast calcifications with suspicious grouping. Biopsy, right breast, intraductal papilloma without atypia. Was recommended to see a breast surgeon as this benign tumor can upgrade. I had a consult with 3 breast surgeons and all stated I should stop transdermal estrogen. Please understand that breast surgeons are not NAM certified. So out of fear, I stopped ERT about 8 months ago and am miserable. I reached out to my original NAMS provider who prescribed ERT in 2019, and she said she could no longer help me due to complicated breast health and told me to listen to the breast surgeons who are not NAMS educated. I then reached out to another NAMS educated provider and she stated, okay to restart transdermal despite the intraductal, am I saying that correctly? Papilloma without atypia and dense fibrocystic breast.
Okay. Now, without giving specific medical advice, I'm going to tell you what the current state of the recommendations are.
Okay.
The only current contraindication regarding breasts and estrogen therapy is whether or not you personally have an estrogen-dependent breast cancer. And even that's debatable. So we're not going to get into that. If you want to, with that conversation, read Avram Blooming's book, Estrogen Matters. But for pre-cancerous or even just benign breast reasons, that is not a contraindication to taking hormone therapy. And let me tell you what that bad old study, the Women's Health Initiative, told us about women who have had hysterectomies and who take estrogen after having had a hysterectomy for menopause. Guess what this large study found? That for women who take estrogen only, not only is there a decrease in the incidence of breast cancer, there's a 23% decrease in the incidence of breast cancer in women who take estrogen after hysterectomy. There is a 40% decrease in the risk of dying from breast cancer if you use hormone therapy. And that never sort of made it out there, but that is well documented. That comes from the investigators who did the Women's Health Initiative, their 20-year follow-up. So I say this generally, estrogen does not cause breast cancer. Let's be clear about that. There may be some combinations thereof that may be better, estrogen and progestin, perhaps, and I say perhaps, that may slightly increase your risk. Estrogen only does not. That being said, do I know if you're going to get breast cancer? I do not. Your risk is your risk. But to answer that, are you increasing that risk by adding estrogen? No, you are not. And again, you get back to that cost-benefit ratio.
Yeah.
If you are miserable and your quality of life is compromised and your cardiovascular health is compromised, then that seems to be a decision that you can make comfortably without worrying about whether or not you're going to get breast cancer. Maybe you will, maybe you won't, because you know what the biggest risk factor is for developing breast cancer? Living long enough to get it.
I was just going to say age, which I learned from
living.
you. It is, yeah, it's living. Yeah. I it never sort of ceases to amaze me how muddled the part of the conversation about risk, benefit, suffering, not suffering becomes. And so I think that's one of the things we're sort of each one of us individually, but certainly as a platform,
Right.
Alloy is interested in kind of clearing that up. If I may just share this anecdotally, I've shared this before, but I was one of those people who did the natural, let me muscle through, let me take every supplement I can get my hands on and spend so much money. And it wasn't until I started hot flashing unreasonably and learned about the connection, the sort of how teed up I was to develop cardiovascular disease. And my father had just died of heart disease, that I finally went, okay, I'm done. I'm going to try it. I'm just going to try it. And within, first night, I got my first full 8 hours plus of sleep that I hadn't even realized I wasn't getting. And my hot flashes cleared up just, like within, I want to say 5 days. It felt miraculous to me.
Right. And I'm going to say this because I don't think it's emphasized enough, Rachel. I'm going to say it again. If you have had a hysterectomy and you can take estrogen only because you don't need to take the progestin if you don't have a uterus, the benefits of taking estrogen only far, far exceed the risks, because you're going to get the protection of your bone, protection of your brain, protection of your heart, as well as your quality of life. And when it comes to breast cancer, you're actually decreasing your risk.
Right.
And decreasing your risk of dying. So for women who've had a hysterectomy, I mean, it's almost, a no-brainer on that in terms of the choice that you make if you so choose. So don't, again, you remember I told you we keep going back to that concentric circle. Once you get outside of your NAMS OBGYN, and all right, this is some inside doctor talk right here.
Sure.
Even though your NAM certified doctor probably knows this, once your cardiologist or your oncologist or whoever has been on record saying don't do it, and that's written down somewhere in your chart, doctors are risk averse too. We don't like being wrong. We don't like being sued. So 10 years from now, you get breast cancer, because remember, because you're 10 years older, not because you took 10 years of estrogen, but you get breast cancer. Then someone's going to come back and say, see, I knew I shouldn't have taken that hormones. So you know what I mean? That's a legal issue. That's not a medical issue.
Yes. And yet it's defining what's happening to you today.
Exactly. Exactly. Nobody wants to be the person who comes back and they said, see, I told you. And once another doctor has sort of recommended against something, but I want you to keep this in mind, they know far less about what we are talking about than a NAM certified doctor does. Far less. Because they're not, just like I don't keep up with the literature in cardiology, they don't keep up with the literature in menopause either. So everybody just works in their little silo.
Yes, thank you. Here's the next comment. I saw a doctor yesterday to get on HRT, and he suggested progesterone for better sleep, even though I don't have a uterus. He seemed highly knowledgeable. I start estrogen, progesterone, testosterone cream tomorrow. I'm so excited.
Well, I'm glad you're excited. You're getting there. Yay.
Okay, go ahead.
But I can't think of a circumstance where I would give someone progesterone, this is Dr. Malone speak.
Yes,
this is whatever. Whenever I'm starting someone on medication, I'm of the less is more, and because sometimes when you start combinations of things, one, if you don't have a uterus, you don't need progesterone. Again, and we get back to the sleep issue. If your sleep and sleep issues are due to hot flashes, well, that's going to get taken care of with your estrogen. I wouldn't give someone progesterone just for their sleep. I'd say, let's see how you do with the estrogen first. All right, then we evaluate that. And then you add things on in layers, because whatever complications or issues that you may not have, then, and if you're doing 3 things all at once, one of which I think arguably you don't even need, then I don't know which one of them is the problem.
Right. And then you have to peel back to kind of figure it out.
And then you're like, okay, was it this? Was it that? And then, so I'd say I would give that approach to say, start one, get used to that, see how you feel. If you need testosterone for other reasons, and I'm not averse to testosterone, and testosterone is one of the medications that does need to be monitored though, even though I said you don't need hormone levels for estrogen, you do for
Mhm.
testosterone, because it needs to stay within a certain range, because you don't want a beard, you don't
Yeah,
want
yeah,
you don't want all
yeah.
those other things that can happen when your testosterone is too high. So monitor that. Testosterone, that's going to be, up to you, but understand that that needs to be monitoring. Estrogen does not. And I would say, generally speaking, you don't need progesterone if you don't have a uterus.
Okay, thank you. I hear that magnesium is good to take in menopause. What are the benefits? What kind of magnesium should be taken? Is it safe to take, not knowing if you're deficient in magnesium?
You know what? Now, this is one thing that I will always do for you. I'll tell you what I know, I'll tell
Mhm.
you what I think, and I'll tell you what I don't know. Okay.
And that's why we love you.
And I don't know. There are people who really tout that, magnesium, and I think it falls in the category of it doesn't hurt.
Mm,
But do I know a specific one for you to take when the specific amounts? I do not. And again, this might be someone who does follow this a lot is Dr. Mary Claire Haver. She
mhm.
talks a lot about magnesium, so go to her. And I'm not going to give you any bad information about stuff that I don't know. So
Fair enough. Should someone with hypothyroid use transdermal versus oral estrogen?
doesn't matter.
Great. What is your opinion on bioidentical? You spoke to this a bit. Bioidentical hormone replacement therapy. What is your
Yeah,
opinion?
I think, all things considered,
Mm-hmm.
bioidentical makes sense. Let's just say,
Mm-hmm.
and again,
Mm-hmm.
this is what we think. We'll,
Mm-hmm.
what we know, what
Mm-hmm.
we think.
Mm-hmm.
Because again, the largest body of information, good, bad, and indifferent, still comes from the Women's Health Initiative that was done with Premarin, which is a natural estradiol, and a synthetic progestin. Now,
Okay.
have there been any head-to-head studies, this one versus that one? No. Um, is there a considerable body of evidence that suggests that bioidentical is better? Yes. And it just sort of, and again, this is what I think. If you had a choice to take something that was just like something that your body made versus something that kind of is close, take the one
Yeah.
is like your body. But that's sort of again, that's a personal preference issue, and not so much with the estrogens do we get into this conversation, is more with the progestins. And let me say this about the bioidentical progesterone. It's great. If you tolerate it, it helps with sleep. You need it if you have a uterus, but some women don't tolerate micronized or the bioidentical progesterone. So is a
Okay.
synthetic progestin bad? No, it's not.
Mm-hmm. Mm-hmm.
Again, it's a matter of understanding how you react to them. And I don't want women to think that they're doing something bad or dangerous or whatever because they're
Right.
taking a synthetic progestin. Get the one that works for you. It makes sense to start with the bioidenticals. And if for whatever reason the bioidentical doesn't work for you, then don't hesitate to think that now I'm doing something risky because I'm trying. And there's several different synthetic progestins. It's not just one that was in the
Okay.
Women's Health Initiative.
Okay. Thank you. Um, this is a great question. This comes up a lot, certainly in the world of wellness, if you will. Is estrogen dominance a thing? I see this online. I see in online experts and some physicians expressing the need to use DIM and other supplements to get rid of the bad estrogen while on MHT. I love this question because so many of us out here are kind of like, motoring along, trying this, trying that. This sounds good. This sounds like it's a thing. School us.
Okay, I'm an OBGYN and I practiced for over 30 years. I'm like estrogen dominant. I don't even know what that is. Okay, so
Have
I'm
you really?
Where did
I
that
want.
come from? When did
Yeah.
that, I don't even know when that became a thing, but I
Hmm.
can kind of surmise where I think that may have come from.
Okay.
And estrogen dominance just means that when you're in perimenopause or the menopausal transition, your estrogen levels are everywhere. It's not,
Right.
when you're in menopause, your estrogens are low and they stay low forever unless you use supplementation, right? When you're in perimenopause, your estrogen, you are constantly overshooting and undershooting what your estrogen levels may be on any given day. So someone who is, let's just use the term that they use, estrogen dominant, these are women that are going to have more cycles when they don't ovulate, so that's when cycles may be, you may get a cycle once every 2 months or, sometimes even less than that. But you're making a lot of estrogen, but you're not ovulating. So you're making more estrogen relative to the progestin because you don't make the progesterone, the natural progesterone, until the second half of the cycle when you ovulate. Okay. If you don't ovulate, you make lots of estrogen, not enough. And so that may be, I think, where the genesis of this estrogen dominance is, where your estrogen levels are too high, not necessarily too low. That's going to happen in perimenopause. And there's no such thing as trying to, balance that with exercise or prayer, meditation.
Right.
It's a physiological thing.
Yes.
And a lot of times women who are estrogen dominant tend to have more bleeding problems. You have very heavy, out of control bleeding because you've got more estrogen, less progesterone. And so if that type of imbalance needs to be balanced by, you guessed it, some hormones. So you can either, for women who have those kinds of cycles, and the thing we didn't talk about is sometimes we do use progesterone. We use progestin in the second half of the cycle, and that's the balance. It's not a herbal supplement. It's not a, whatever. I don't know what people are selling, but it's not that. It is you are bringing the estrogen levels and the progesterone back into alignment the way they were. So long answer.
Thank you. No, absolutely helpful. Someone asked, does anyone else have itchy inner ears? I recently learned that can be an effect of perimenopause. Can MHT help with this? I can tell you yes, and yes. Am I allowed to answer that one?
Yes, you can.
Okay.
Yes.
Okay.
Yes.
Okay, great. Thank you. Can estrogen help
lichenschlerosis? Is that I presume that's what they're saying.
Yeah, I think so.
Yeah. Generally not. Okay. But I say general. Let me just say again, not going to say specifically. When lichen sclerosis is a dermatologic condition but it happens in the vulva and sometimes in the labia minora where there's thinning of the skin. It helps a little bit, but sometimes it requires a steroid because again, a lichen sclerosis it's not like the thinning that you get from lack of estrogen. It's really a dermatologic issue. And sometimes we use estrogen because clearly thinning on top of the lichen sclerosis is certainly not going to make it better. But sometimes you do need something more than estrogen. So, again, just know that that's a different thing.
No, that's so helpful. And just to hover on that just a second longer, using vaginal estrogen, let's say you've been using it and everything's great, might you still develop lichen sclerosis?
Yes, because two different things.
Okay, great. Two different. Terrific. I feel like my nerves are on edge most of the time. It doesn't take much for me to feel extremely nervous or anxious. Is that related to menopause?
Yes.
Yes. Yes. I'm not laughing at this person. I'm laughing at myself saying, had that.
It's in the top 5. It's in the top 5 symptoms, So yes, that can very well. There's a lot of the things that we used to attribute to, women. Oh, well, then you're just, it's your temperament. It's women. You're being hysterical. You're just anxious. Well, yeah. It is going on. It's going on in your head because the estrogen and lack thereof is affecting your brain. And where does everything register? In your brain. So yes.
Right. Okay. Thank you. Can my mom, 81, start progesterone cream for sleep? She has tried almost everything else and it doesn't seem to help much, aside from the CBD THC gummies, which are expensive.
I would say, honestly, no. And the reason why I say no is because there is no progesterone cream. Who knows what that is? Progesterone creams are compounded. someone's making it. I don't know how much is in it. I don't know whatever. I would say, and again,
Right.
it goes back into the category. Remember, I told you there's a lot of sleep disturbance that just comes with aging. And it may mean, again, getting some other, but I would not use progesterone cream for various and sundry reasons in an 81-year-old for sleep problems.
Okay. Okay. Thank you. Sorry. Hello. I've been experiencing warm, flushed face, but no sweating. These last a few hours, my face turns red, feels flushed. I'm 56,
Yeah.
1 year post periods. Can this be a menopausal symptom? What do you think of estrogen?
Okay, Rachel, I'm gonna let you answer that question. I know you know the answer to that
Yeah.
one. Could that be a symptom of menopause?
It certainly could. And 56, 1 year post period, absolutely. You are in it. You are in it.
You're in it.
What do you think of estrogen?
All right, I'm going to go back to what I said earlier. The most effective treatment for the symptoms of menopause is menopausal hormone therapy. Period. End of sentence.
End of
You know,
story. Excellent. Okay. What is the highest dose patch of estrogen you can use?
I think the highest dose patch that we have, and let me think about, is 0.1. And it's hard to understand because the doses in the patch are not equivalent to well, they're equivalent, but they're not the same scale really
Right.
as what you take orally. But I don't think there's a patch more than we have a 0.05. They when they were driving the patches, when they were changing doses on patches, they kept driving them lower, 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 instead of
Yeah.
going higher, higher, higher. And I'm not, don't quote me on that, but I'll have to,
Okay.
but I think that the highest one that we have at Alloy is 0.1. I think that's
Okay.
correct.
Is there anything women who have had breast cancer can take, specifically triple negative breast cancer? We can't talk about this cancer piece enough.
Yes.
It's a big one.
Again, I would certainly say read Dr. Avram's book. But again, all right, let me tell you what I think and what makes some sense. You remember if I told you that the contraindication is that if you had an estrogen sensitive breast cancer, if you believe that? Well, if you don't have an estrogen sensitive breast cancer, then you have to ask yourself the question, well, then if it's not sensitive to estrogen, then how is estrogen going to make
Right.
that better or worse? Okay,
Right. Right.
That's my way of thinking about that, one.
Okay.
And two, there are many circumstances where, again, where it requires a conversation that you talk to your doctor, because a lot of the triple negative breast cancers tend to happen in younger women. And so you're going to have to weigh, again, what those other long-term implications are, because sometimes you might have been made menopausal because of your chemotherapy for your triple negative breast cancer. So, again, weigh your risk of cardiovascular disease, Alzheimer's, quality of life, against that risk of, and so I'd have to say, it can and should be considered. And it's just a matter of talking to your doctor. And again, I'm going to refer you to the North American Menopause Society's 2022 guidelines, which has taken away that hard and fast, never, never on breast cancer. It's an individual decision based on your treatment goals and what your symptoms are.
Okay, thank you so much. And I hope that this next question got answered in that as well. My mother had breast cancer. Does that disqualify me from getting HRT? You spoke about this half an hour ago.
No,
Thank you.
it does not. A family history is not a contraindication for hormone therapy.
Great. Can anyone take vaginal estrogen? My doctor said that she doesn't recommend it and that I should use moisturizer.
Rachel,
okay.
You got that.
The answer is yes. Moisturizer does not suffice. Please, please, any and all of us should be using vaginal estrogen, start in perimenopause, use it forever.
Yeah.
Go ahead. I was just going to say, I was thinking of some conversations I've had with urologists who've spoken about vaginal estrogen. These are the terms they put it in, is preventative medicine, helping with UTIs, painful sex, urinary tract infections, prolapse, bladder, vaginal. I know I'm missing something, but I turn it to you.
And that's true. All right, you're right. Everybody can use vaginal estrogen, but let me just make a distinction for you so you understand. Vaginal moisturizers, and these are just things that you just use every day because you feel dry or itchy, you're uncomfortable,
Right.
They are treating symptoms, not the cause. Vaginal estrogen goes to the cause. Vaginal moisturizers are not the same as vaginal lubricants. Lubricants are used when you have sex, either alone with sex toys or with a partner, where there may or may not be penetration involved. Just because you use vaginal estrogen does not mean you may never use a lube, a vaginal lubricant. You may need, because lube is your good friend, and you should have some handy at all times if you plan on having pain-free sex. And you don't need to keep driving up and using more and more vaginal estrogen. You use vaginal estrogen as preventative, but might you still need to use lube? Yeah, maybe.
Certainly.
So have some handy.
Okay, great. Thank you. I just want to let everyone know we're going to go about 8 more minutes. Dr. Malone can give us that time, which is very generous of her. So just hang in there. I'm going to get to as many more as I can. Any advice for night sweats that, while decreased with adding testosterone to my HRT, still happen as I am on the back end of my pellet cycle? Yeah.
Okay. Look at my
I know.
face.
Let's get into it. I know. We're not pellet fans.
We're not pellet fans. We're not pellet fans. And this is, I often say when someone says, no disrespect, right before they're getting ready to disrespect.
Here it comes.
Here it comes. You asked for it. You got it. Toyota.
Yeah.
All right. Pellets are not, let me just say this. I know that there are people out there who are on pellets and love them. Okay. God bless you. All right.
Yeah.
But the reason why I would never recommend pellets as a first-line therapy is because, remember I told you things that are compounded? Somebody's making that. And is what they said in it? I don't know. I hope so.
Who knows?
Somebody's making that up, and the combinations thereof can't be individually adjusted. If I put you on testosterone, that again, all testosterone has to be compounded. Let's say this, because there's no commercially available testosterone for women. That being said, if you use it, if I gave you too much or you didn't like it or your face broke out, I could say, stop using that. If you get a pellet and it's too much, too little, whatever side effects you're having, too bad, because it's now in your butt and it's just got to wear off. So you don't always have assurance of the consistency of dose. You don't have the ability to individually manipulate the components. If it's more, you need more of one, less than the other, because it's all in one thing. And I think thirdly, the most important reason is that they are expensive. And let me say this, expensive, not covered by your insurance. A lot of times there are some doctors who sell them. And I would say, just be careful. Because again, Medicaid, and it varies tremendously on the cost of pellets, but some of them are, hundreds of dollars, up to $1,000 per injection. And that to me is just a lot. That's me.
Yeah.
So
no,
I'll let you
fair
decide
enough.
on that, but that wouldn't be my first line recommendation. When you can get all of the components individually that are FDA approved, with the exception of the testosterone, and I'll even take that back, the testosterone, it's FDA approved for men. I find that it's harder to dose women with the ones that men use, because now it involves syringes and it involves stuff, because women only need 1/10 the amount of the dose is given for men. And it's hard to titrate, so I'd say that would be the one case where I'd say, you know what, if you have a reputable compounder that could give you some that you could use on a daily basis, I would go that route as opposed to trying to cut a little piece off a testosterone patch or something.
Okay. I'm gonna get to 2 more questions and let you get on with with all that you are doing. We're going to need to schedule this again on the back end of your tour, because the questions are helpful, fascinating, interesting, and critical to our health. So I so am grateful for your time. Does birth control cause shrinking of the clitoris, lower testosterone, and lower libido? We got to this a little bit. Do you recommend testosterone ever as part of the MHT regimen? You just spoke to this.
Yeah.
So perhaps the clitoris part you might speak to specifically.
Well, let me say, again, this is all part of our birth control pill bashing that we have.
Yeah.
There are some women who will take birth control pills and notice a change in their libido. Absolutely. They might find a change in their mood because the way birth control pills work, and this is why they work particularly well for acne, that they do produce what's called a sex hormone binding globulin, or SHBG, which its purpose is that it sucks up the extra testosterone that's percolating in your system. And part of a normal sex drive, women make testosterone, and over our lives, we make more testosterone than we make estrogen. So yes, it does have a component in libido. Birth control pills sort of suck up that extra testosterone, which might give you great skin.
Right.
But it might dampen your libido a bit. If that's noticeable, then maybe going to a different one would be better. The same thing is true on, you have testosterone receptors in your vulva. And again, that some women have vaginal dryness on birth control pills. Again, if that's your reality, we switch. But I come back to what I'm saying. You know what else is a very, very potent libido inhibitor? Fear of pregnancy. Every time you have sex,
that's for sure.
that you are sitting there worried about, so you, then, I'm like, oh, okay. But again, I believe it. I hear, I have dealt with women who have told me these things. I believe them. So yes, and if that is your reality, then we have alternate birth control options for you. But for most women, that is not the reality. And I would say, I caution you when you hear people saying things like this, and they are certain subspecialties or, who deal with sexual dysfunction. Remember, they're only dealing with problem people. So their perspective may be skewed because they're only going to see people who are having sexual dysfunction or these are dryness. That's their world. But for a general gynecologist who sees everybody, the happy people and the unhappy people, they're more happy people than unhappy people. And that's what I want. And everybody's perspective really gets skewed by what they see. The happy people who are doing well on their birth control pills are not seeing a sex, of someone who has a degree in sexual medicine because they're like, I'm good. So weigh it, figure out what the issue is for you. And no, we've got lots of good, reliable birth control, but each and every one of them has its own personal risks and benefits and side effects profile for that. Any of them do.
Yeah, thank you for kind of amplifying that again. We get sort of stuck in the minutia about where we should be and how it should look and how to gauge all of that. When really, if we dial in, we may be able to answer our own questions. And so with that, I want to just ask you this, because this comes up quite a bit as well. And someone asked it here, you touched on it earlier, but just to kind of close the loop. Is there a maximum estrogen plus progesterone? Is there a max? Is there a max? And I guess, again, you've spoken about the individuality of it. People will always come back to the safety part because we don't know and because we've been fear-mongered for so long. So how do we, I guess, ultimately sort of go in armed to an appointment or speak to a menopause practitioner, assume they know way more than we do, and sort of go, okay, this sounds right. What should we be looking for?
Yeah, and I think, in answer to your first question, is there a max amount? that is, I told you, once we're outside what is typical, what is going to really serve probably 97% of women in the standard doses that we have. There are different combinations, but again, that's one of those situations where I would have to individualize the treatment. I would actually have to do, the testing that I said, well, why are you not absorbing it? Why maybe go a different route as opposed to keep driving up the dose? Because again, as you start to get higher and higher with your estrogen, and bear in mind, a 3 milligram dose of estradiol, which I have, to be quite honest with you, I've never prescribed, but some people need that. I have not given it personally, is the amount that's in a birth control pill. So the same contraindications that we would use for birth control pills would apply to someone who uses a 3 milligram estradiol dose. They need to be monitored. You have to make sure there are no cardiovascular issues. You don't smoke, that kind of stuff. But there's no one pat answer to that.
Right. The viewer who brought up birth control pill a lot did say not bashing at all, really. She's genuinely interested in the science, and I know this to be true. So thank you for all that you spoke to about that. I hate to let you go, but I have to. And I am so thankful for so many of you who joined us today, who sent Dr. Malone your questions. Just one more little personal plug about your book, because it really is, it is a uniquely special resource. It is grounded in science, friendship, personal and professional guidance. And it really is sort of like a prescription, not a literal prescription, but a prescription for forging ahead, for sort of seizing health now, forging ahead healthy later. Many people have chimed in wanting to know if you're going to be coming to their city. I will tell you, because I like to say it out loud, that that I will be tag teaming with Dr. Malone as the year goes on, enjoying some cocktails and conversation events here, there, and in many places. And her book tour is alive and kicking, essentially, and you'll be going to many cities around the country, speaking about that. Finally, Dr. Malone, is what do you want for all of us listening to this call now and later on our YouTube to sort of walk away with today?
What I really want women to know is that, the more you know, you're never going to be ill-served by having more information. And I want you to take this information not as a directive, but I want you to take it so you can make better decisions for your healthcare. And I think that if I had to say anything, is to let you know that you have way more power in this interaction than you think. And I think if you're not being served by whomever you see, then you should really exercise your other options, because, as I said, that's why Alloy exists. And that's why I wrote my book. And because I want you to know how much control and power you really do have. We don't have to just accept the inevitable. If that does not have to be your course. And for those of you who really would like to come out, and I would love for you to come out and see me. I'm posting different dates as we go along, but you can follow me at smalonemd on Instagram, or you can go to my website, drsharonmalone.com. You see how easy we made that? And
You did make it easy.
There's information about my book and pre-order, and you'll also, and I will, as dates are added on Instagram, my tour starts on actually April 7th. Then we'll add cities, and hopefully I will see some of you in real life out there.
Thank you so much, Dr. Malone. A pleasure. Thank you, everybody. We will see you soon. We will see you again on the other side of your tour. Thanks for today. Bye, everyone.
Thank you, Rachel.
Bye. Thank you.